Indication for urodynamic evaluation: recurrent UTI in patient with neurogenic bladder, recurrent UTI in patient with neurogenic bladder, urinary incontinence, urinary frequency, large post-voidal residual, that is retention, deterioration of upper tract, monitoring of voiding pressure, for assessment of high risk for back pressure changes, evaluation and monitoring of pharmacotherapy. Normal urodynamic findings are intravesical pressure, urethral sphincter pressure, urethral sphincter electromyography, urine flow rate, urodynamic study at different level. Urodynamic study at different level of injury site based on external sphincter EMG and bladder pressure during filling and voiding is initiated by relaxation of sphincter before the bladder contracts, low pressure emptying. Normal pattern suprapontine lesion contraction occur during filling, which the patient tries to suppress. Coordinated sphincter relaxation occur. Incontinence is observed. Intrapontine and suprasacral lesion contraction occur during filling and sphincter co-contraction due to reducer sphincter dyssynergia and high reducer pressure. Sacral or infrasacral lesion, minimal or no bladder contraction or sphincter activity present. Video urodynamics or fluorourodynamics. It takes pictures and video of the bladder during filling and emptying, useful for detection of site of bladder outlet obstruction and reducer sphincter dyssynergia. Considered as gold standard for bladder assessment in neurogenic bladder. Classification of neurogenic bladder: anatomic classification by Bose and Kumar. Anatomic classification based on level of injury: Hale-Bratley, suprasacral, supraspinal, conal, infrasacral, coda equina. Functional is based on systematic finding. International Continence Society reflects uninhibited autonomous motor paralytic sensory neurogenic bladder. Madersbacher classification based on the type of lesion, contraction states of the bladder and external urethral sphincter. In suprapontine lesion, bladder is overactive and sphincter is normoactive. In suprapontine lesion, bladder is overactive, sphincter is normoactive. In spinal lesion, bladder and sphincter are overactive. In spinal lesion, bladder and sphincter are overactive. In lumbosacral lesion, bladder is overactive and sphincter is underactive. In subsacral, both bladder and